Catherine Brandos, Madison Chase, Richard Downing, Joel Duberstein, and Maddie Farley. Our objectives are for the learner by the end of the presentation to be able to identify the cardiovascular, respiratory, and musculoskeletal complications of immobility, to also identify 3 nursing interventions to reduce respiratory complications, 3 nursing interventions to prevent the formation of DVTs, and 4 nursing interventions to help prevent deterioration of the musculoskeletal system. Immobility is defined as a limitation in independent, purposeful, physical movement of the body or one or more extremities. Several causes leading to immobility, including this list. It's not a complete list, but these are some of the common issues. And a crucial part of immobility is the ability to be able to assess the patient for mobility, which we'll get into later. These are some of the main respiratory complications of immobility. In a nutshell, it's the buildup of secretions and the inability to take deep breaths that are the main contributors to respiratory issues. Lying supine restricts rib cage expansion and the lungs don't pull in enough air. This causes the alveolar sacs to not fully inflate and they therefore collapse. The reduced oxygen also leads to hypoxia and hypoxemia. The pulmonary embolism will be discussed with DVT, but not being able to cough effectively due to rib cage restriction restricts the body's natural mechanisms for removing mucus, and that pooling of mucus leads to pneumonia and other respiratory tract infections. Also, the positioning also lets the airways be smashed so they're not as dilated and reduces oxygen. Our nursing diagnoses basically center around airway and breathing. Some nursing outcomes that we'd want to see are oxygen levels within normal limits, clear lung sounds, and for the patient to be able to breathe comfortably without distress. It's necessary for the nurse to be constantly assessing vital signs, oxygen sats, keeping the patient as vertical and as upright as possible. Bed positioning is also important. To the right is an incentive spirometer that patients use as a tool to get their lungs to expand. They basically exhale and breathe deeply to try to get this little piston to move up to the goal. Richard is going to speak more about the nursing interventions.
Some of these interventions that we can do is primarily first is we want to assess the patient for their ability to breathe. So this could be oscillation and so forth. Basically you want to do this every 1 to 4 hours, and what we're listening is for crackles, wheezes, diminished breath sounds. We're also going to be looking at the rate, depth, and effort. If the client is having problems with this, it could be an indication that there's secretion buildup, because we can see this in an increased respiratory rate. We're also going to be wanting to take a look in combination with stuff for the O2 saturations, because if there is a secretion buildup, we could be seeing a decrease in the O2 sat readings. One of the other things with having the bed in a semi-shallow position at a 30-45 degree angle, what this does help decrease aspiration from these secretions. It also lowers the gravity and weight on the chest, so the client is able to breathe with a little less effort. We're also going to be wanting to help the client with deep breathing exercises by performing controlling coughing. We will show you an example in a moment with huff coughing, but basically we're going to have the client take a deep breath, hold for several seconds, and then try to cough 2 or 3 times with the upper mouth and the upper right abdominal muscles. Beyond that, we can also try percussion, vibration, oscillation as appropriate. What this does is help loosen the mucus that may be built up, so we can use the coughing exercises to help get those loose. Within this, we do want to encourage the client to take in fluids within any dietary restrictions that the client may be on. And we also have a picture of the tripod position, which helps the client be able to expand their chest a little bit easier.
When doing a high-level huff, inhale slowly and deeply through your nose until you can't take in any more air, and then sniff to take in even more air. hold your breath for 3 seconds. While maintaining an open airway, perform a short, quick, and forceful exhalation. Again, putting your tongue on the roof of your mouth or making an exaggerated O with your mouth may help you keep an open airway. Great job!
Okay, we're also going to talk about cardiac issues with immobility. So first, DVTs, what we're worried about is in Virchow's triad, venous stasis. So immobile patients, their blood's pooling in the extremities and it can form clots. And so what we'd like to do is first assess for any clots in our patients, because if there are clots, we don't want to move them around and risk having pulmonary emboli or strokes or other issues with clot detachment. And we also want to use some preventative measures, which can be compression devices or also getting them up and mobile as soon as possible. And things like heparin and low molecular weight heparin are blood thinners that thin out the blood and reduce the risk of clotting. So we're going to want to assess within 24 hours of our new patients, and also, again, with any clinical changes, and continuously for our immobile patients for long periods of time.
So I'm going to talk a little bit about deconditioning. So deconditioning may occur during periods of prolonged bed rest or immobility. This is typically associated with activity intolerance, elevated resting heart rate, and orthostatic intolerance, which is relieved by returning to a reclined position. So basically, patients don't like getting out of bed and they find getting out of bed exhausting. So this is more common among elderly patients who spend most of their hospital admissions confined to their bed. So prevention of deconditioning is a vital part of bedside care. Patients that experience deconditioning are more likely to also experience worse long-term health outcomes, such as decreased physical functioning and decreased quality of life. So two good methods for preventing deconditioning are ambulation and resistance training. Ambulation is necessary for maintaining proper heart function. If the patient is left in bed, the body will acclimate to this environment, and this will make the recovery process more challenging. So with resistance training, this mitigates cardiovascular deconditioning by promoting body movement and maintains this cardiovascular functioning. Muscle contraction also promotes venous return to the heart, which can be challenging to maintain when a patient is in bed rest. So in an emergent environment, the nurse should encourage the patient to perform these exercises as soon as possible, and they should refer any patient that is unable to do these exercises to a physical therapist for more targeted treatment.
This is my dog, Bailey. She's going to demonstrate it for us. So our nursing diagnosis, if we were to have a DVT, would be ineffective peripheral tissue perfusion, and we would know this by acute pain, edema, warmth, tenderness in the limbs. So our interventions would be to reassess using Virchow's triad and other comorbidities. We'd want to check and we'd want to use compression devices, 4 hours on, 4 hours off for our immobile patients. And also education for our patients who are chronically immobile and who leave the hospital to prevent these DVTs from forming.
So we're going to look at some diagnoses and interventions for cardiac deconditioning. So first, Just an example of a nursing diagnosis would be activity intolerance related to orthostatic intolerance, secondary to deconditioning, as evidenced by the patient saying something like, "I'm too tired to get out of bed today." So ways to combat this, like I previously mentioned, are ambulation and resistance training. So some examples of nursing interventions would be the nurse assisting the client with range of motion exercises in bed if they can't get out of bed 3 times every day, or the nurse assisting the client while ambulating 20 feet in the hallway every 4 hours, or the nurse teaching the client or the client's family to recognize signs of physical overexertion. So this picture on the right is actually a respiratory therapist and a physical therapist ambulating someone who is currently undergoing mechanical ventilation, which I thought was pretty interesting. So there really is a lot of things that you can do to make sure that your patients don't slip into deconditioning.
Next, we're going to talk about the complications of immobility on the musculoskeletal system. According to the article, the impact of extended bed rest on musculoskeletal system and the critical care environment. Being on bed rest or immobile for 1 week shows significant loss in muscle mass, strength, and bone density. It is seen that there can be a 40% muscle mass loss due to 1 week of immobility. There is a greater calcium absorption during bed rest. Within 1 week, we can see 1% of bone density loss.
These are some examples of nursing diagnoses related to immobility on the musculoskeletal system. So impaired physical mobility related to medically imposed bed rest, and impaired walking related to limited physical mobility and deconditioning of body.
Here are some nursing interventions, and we have videos to show you next. So first, we will assess the patient and their strength. Full strength is 5 out of 5, meaning they have strength against resistance. We'll promote early ambulation, and we'll also use mobility devices and use passive and active range of motion. There are 3 ways to promote range of motion. First is active. Can you move your arm in a circle for me, Olivia? That's active. If the patient can't move their arm by themselves, they could do assistive range of motion, where the patient assists themselves. Beautiful. If the patient can't assist themselves, we can do passive motion, where the nurse helps the patient. Good job. Okay, we're done. Hi, Olivia. I'm going to be your nurse today. Can I assess your strength? Of course. Okay, can you squeeze your fingers as tight as you can? Good. I'm going to assess your arms too. Okay, push back on my arms when I start pushing, okay? Good job. I'm going to also push on your feet. Can you push back? Nice job. Okay, next I'm going to teach you the 5 ways to assess for mobility. Olivia, can you push yourself up in bed? That's the first way. The second way, I'm going to have you dangle your feet off the side of the bed. We're going to make sure that you're not dizzy. Are you dizzy? No. The next way, we're going to assist the patient to a chair. Beautiful. Now we're going to assist you to stand up. Can you stand on your own? Yes. Do you think you can walk on your own? Yeah. Beautiful. And then those are our videos to show you our interventions for immobility on the musculoskeletal system. Thank you for watching our presentation on immobility and how it affects the respiratory system, cardiac system, and musculoskeletal system. But here are references for our presentation. Thank you.